Hello everyone, I'm Dr. Pareek, a cardiology fellow at Copenhagen University Hospital, Gentofte in Denmark. I just attended the annual Danish Society of Cardiology meeting. It was so good to be back in person in Nyborg, right at the beach. Terrific to see all your friends and colleagues once again in this great forum. Now I'm here to report on the amazing rapid fire abstract session with a number of very talented young superstars who got to showcase their work. Lots of interesting findings and food for thought, and even better, major institutions from all over the country were represented. So let's kick off with the first study by Peter Hartmann Frederiksen from Odense University Hospital, looking at the impact of Impella RP and Inotropy on regional left ventricular function in acute cardiogenic shock. This was actually a translational study in which the right coronary artery was embolized in 14 pigs. This led to cardiogenic shock, initiation of Impella RP or medical inotropy with norepinephrine and milrinone. The endpoint assessed was longitudinal strain at predefined intervals up to 180 minutes. The investigators found a significant improvement in strain with both types of treatment, driven by changes in the lateral wall, and most pronounced in the inotrope group. One of the limitations included the fact that the most pronounced effects were seen on the ventricular wall, not expected to be affected by embolization of the right coronary artery. So perhaps our interventions are most useful in the stunned and less so in the infarcted ventricle. I look forward to learning more from the DanGer shock trial that is assessing the utility of Impella in patients with myocardial infarction complicated by cardiogenic shock. The second study that we are going to discuss is a sub-study of the podcast trial. Love that name, by the way. Now, the podcast trial in its entirety is a large randomized trial featuring 1,000 patients with heart failure, an ejection fraction of 35 to 55%, and an ICD. These patients will be randomized to either continuing standard therapy alone or standard therapy with added potassium supplements and MRAs, aiming for a high target potassium level of 4.5 to 5.0 milliequivalents per liter. At the abstract session, Ulrik Christian Vinsløv from Rigshospitalet in Copenhagen presented findings from his sub-study of 50 patients. The outcome in this study was a change in myocardial deformation assessed as global longitudinal strain and E' at 6 weeks. Interestingly, global longitudinal strain changed significantly more in a positive fashion in the intervention group, as did E' and markers of mechanical dyssynchrony. The changes were minus 1.6% and 1.3 centimeters per second, respectively. So it's unclear whether these changes are clinically meaningful. Furthermore, I think one may discuss whether MRA should be considered for all patients with HFmrEF and HFpEF, particularly given the findings from the now well-known geographical sub-study from TopCat. Nevertheless, the study does add to our current knowledge base on how to optimize potassium in patients with heart failure, especially because most efforts so far have focused on how to lower potassium in order to provide room for guideline-directed medical therapy. For the next one, We'll be shifting gears quite a bit. Bilal Shafi from Bispebjerg Hospital in Copenhagen used data from 1,142 participants in the Copenhagen City Heart Study, known in Denmark as Østerbro-undersøgelsen, to examine associations between socioeconomic factors and 184 cardiovascular biomarkers. A total of 14 biomarkers were significantly associated with length of education on multivariable analysis. Similar results were obtained for income. The authors conclude that their results may increase our understanding of the biological mechanism related to the social gradient in heart disease and may help individualize therapy. While these are certainly interesting hypothesis-generating data, it's difficult to make finite conclusions regarding causality because of the cross-sectional nature of the study. I would love to see some more longitudinal type data on socioeconomic factors, biomarkers, including, quote-unquote, their burden, changes over time, and risk of cardiovascular events. All right, moving on to CTFFR. Nadia Iraqi from Aarhus University Hospital presented the rationale and design of FlowPromote. This is a randomized controlled trial of intensive lipid lowering with a statin plus ezetimibe versus standard lipid lowering in patients with stable coronary artery disease. Specifically, patients with stable angina referred for a coronary CTA with at least 150% or greater stenosis will undergo FFRCT. If a value of 0.8 or less is found, they will be randomized to set treatment regimens for a total of 18 months with repeat scans at 9 and 18 months. This is a very interesting proof of concept study that may form the basis of using FFRCT in future mechanistic trials or other studies of atherosclerosis, and perhaps in clinical outcome studies that could add to what we already know from the FAME and ischemia trials. So far, we have discussed cardiogenic shock, heart failure, biomarkers, ischemia. So now it's time to talk about valve disease. Mohammed Sabah from Rigshospitalet presented data from an elaborate study on patients with severe aortic stenosis, referred for SAVR or TAVR, with or without left ventricular hypertrophy. A total of 53 such patients underwent coronary angiography with measurement of metrics of myocardial blood flow and microvascular resistance. Global flow and global resistance did not differ between patients with versus without hypertrophy. However, indexed hyperemic blood flow was significantly lower and hyperemic resistance significantly higher among individuals with hypertrophy. This study actually goes along very nicely with our opening lecture by the distinguished Professor Jerome Bax on imaging in aortic stenosis. It's not just about the valve, but the disease spectrum is much more complex. The investigators went on to reveal that their findings were potentially reversible after valve intervention, and that the degree of reversibility did not completely depend on regression of left ventricular hypertrophy. The sixth abstract also embraces a hot topic, i.e. optimal platelet inhibition in STEMI patients with a high bleeding risk. Mia Ravn Jacobsen from Rigshospitalet in Copenhagen conducted a single-center descriptive study of STEMI patients who underwent PCI and had high bleeding risk, defined as a precise DAP score of at least 25. Of more than 4,000 patients included, about a third had high bleeding risk. These were more often women, older, had a greater comorbidity burden, and higher inpatient mortality. These individuals also had higher risks of both bleeding and thrombosis over the long term. But more interestingly, only a third of patients with high bleeding risk were discharged on clopidogrel, the rest on more potent P2Y12 inhibitors. This really sets the stage for the DANDAP trial that will hopefully add to what we already know from MASTERDAP, Popular Age, and other relevant clinical trials. This study will also help examine the utility of the precise DAPT score, not just for reducing the duration of DAPT, but also for choosing the P2Y12 inhibitor agent. And now it's time for our final presentation using data from the Copenhagen Baby Heart Study. Mette Marie Nørgaard from Herlev Hospital used this cohort to examine whether maternal risk factors like smoking, age, and overweight were associated with congenital heart defects in their offspring. More than 20,000 pediatric echocardiograms were performed. Older maternal age and greater maternal BMI were both associated with significantly smaller left ventricular cavities in their offspring, while smoking was associated with increased wall thickness. These are likely incentives to stay healthy while pregnant, though we have yet to learn what this means for cardiovascular risk over time. All in all, what a terrific rapid-fire abstract session. And I can't wait to read the full manuscripts. I hope all of you enjoyed your Danish Society of Cardiology meeting, as well as this session. This is Dr. Manan Pareek, signing out for now.